Good afternoon or good morning, everyone, depending on where you are in the world. I'm going to give you a little introduction here. So, what really is syphilis? It's a bacterial, sexually transmitted infection. It comes in the form of a spirochete, which you will see a little spiral looking um, picture of it on some of the slide decks. It is caused by skin to skin contact with a person with symptoms during vaginal, anal, or oral sex. It's not spread through casual contact with objects like clothing, doorknobs, toilet seats, pools, right? So you really have to have that skin to skin contact to get it. And it gets diagnosed in stages, and this is kind of a critical piece. There's primary and secondary, which are the general most infectious times. There's latent that comes in early and late latent, and tertiary, which is generally found as a neuro or an ocular eye or oto ears type of problem that's happening related to the infection. And that can happen at any time. So the term tertiary does not mean that it's just later. It means that it could happen really at any time. So be on the lookout for that as something that, when someone's having an unusual set of symptoms like that, it could be related to a syphilis infection. So just have that in the back of your mind. And the cases have increased dramatically across the United States, and I'll get into a few slides with data on that. Next slide, please. Okay, so with this set of map, it provides a visual of the increase in syphilis across the country from 2014 to 2023. The 2024 data is still preliminary, so I'm only going up to 2023 because that is finalized data for today's presentation. So the change you see here is for women specifically on this map, and it's a really drastic shift over time. You can really see how there were very few cases in most parts of the country, and now almost the entire country has very many cases, or a very high level of cases, including territories like Puerto Rico, and our islands and Hawaii and Alaska far off to the north, right? So this is in fact affecting the whole country. And for women, the rate increased to 636.4% over this period of time. So in 10 years, it increased that much. For men, it increased 103%. So there's still an increase for the whole population, but really dramatically for women. So take a look at your state and see how it's changed over this course of time. Next slide. And congenital syphilis occurs when syphilis is passed down from woman to a child. It's preventable if a woman is tested and treated during pregnancy. It can cause really serious complications, including stillbirth and death for the child or the baby. And like general syphilis, congenital syphilis has been increasing throughout the United States, in large part due to the increases in cases among women. Next slide. So as we saw earlier, there's been a significant increase in congenital syphilis across the country and some U.S. territories. Again, take a look at the map in the surrounding areas. This is really dramatic. Congenital syphilis was something that you see here in 2014. Some states saw absolutely no cases whatsoever, and most states saw very few cases, to now, again, almost the whole entire country is affected and has many more cases than they used to. Next slide. All right, there's a lot going on in this chart. The blue bars show the number of reported cases of congenital syphilis growing from 462 cases in 2014 to 8 times as many cases at 3,882 in 2023. That is an increase of over 740%. The dotted line shows the growth of all stages of syphilis among women. So often what you're seeing is primary and secondary, which is the lower line on the bottom, which hasn't changed that much, but this really big increase is in diagnosis among women of all types of syphilis, which means that more people are actually getting found and tested when they're not in an infectious phase and don't have obvious symptoms, right? So I think that's a good sign that clinicians are really looking out more, but we need to do even more than we have been doing to catch more cases and prevent congenital syphilis. Next slide. All right, so why is this even important? In 2023, there were 252 congenital syphilis related stillbirths. That is an 800% increase. Again, these percentages of change are really humongous. 800% increase since 2014. In 2023, there were 27 congenital syphilis-related neonatal and infant deaths that were reported. So that's an increase of 237%. And these are the most serious potential outcomes of congenital syphilis. But infants that survive congenital syphilis diagnosis, there's many other health problems that can affect their development and growth and their health for the rest of their lives. And again, I have to keep repeating, it's 100% preventable through testing, correct staging, and appropriate and complete treatment for the stage the patient is diagnosed at. So again, testing and treating at the right stage and at the right dosing is the critical part to prevent this for women and babies. All right. So thinking about congenital syphilis and syphilis with migratory and seasonal agricultural workers, there's some reasons that they may be at more risk for syphilis. And I would say that many of these reasons will apply to other folks who come into your clinics as well and other people from different populations and communities. So really think about how this might apply to anyone you're seeing at your clinics. Transportation and rural locations. So many of these folks work out very far out in rural areas because they're working in farming and crop management. And so they may not have any transportation of their own. There may not be bus service in those areas, and the location of clinics may not be anywhere nearby, or there's very few of them. They have often a lack of health insurance or other healthcare access. They may fear and mistrust the health system and its providers, either related to previous care that they have experienced, or just in general not being comfortable going in and using the system for a whole variety of reasons. They may be relocating frequently. So if they're following crops, planting and harvesting, they may have to move regularly throughout the year. And so not knowing where the new clinic is in their new location, or just not having any way to figure that out. And maybe they started treatment somewhere and then they move and then they don't get connected again. There is an increased risk for sexual violence and intimate partner violence, in particular for this population. For folks who are working out in the sun all day for extended hours, it is known that that can really affect people's ability to manage complications or perhaps disagreements with a partner. They may have experienced violence on their way or when they're moving around. And so there's any number of reasons why there's an increased risk for these kind of sexual violence and intimate partner violence among this population. They are often isolated. They may live with few people who aren't their friends, who aren't their family, where they're working. They may have left a partner in one community as they move around. And so they may be looking for some way to just be comfortable and find a new partner that they don't know anything about. And then economic and health related reasons. It may be very difficult for them to take time off work. They may have a job that does not offer any kind of sick leave. They may be working a job that is piecemeal, so they get paid per rate of what they picked. And so missing a half a day of work to go to a clinic means they miss a half a day of pay. And so, there may be other priorities for them that make it hard for them to even consider going to a clinic if they're having symptoms. And finally, I'll mention language. They may not speak English or English very well. And so knowing whether your clinic actually has bilingual staff or has access to interpreters really easily and quickly if they've gone somewhere where they haven't had those services, it could really deter them from wanting to go in somewhere else. And then finally, I'm just going to say, while I'm not showing this data here, any of you who may have attended our webinar last year on congenital syphilis, we were able to show, that, most migratory and seasonal agricultural workers come from the Hispanic or Latino community. And while women in that community have the lowest proportion of syphilis cases, babies of parents that are Hispanic or Latino have the highest proportion of congenital syphilis. And so that's indicating to me that pregnant Hispanic or Latino people are not being tested or treated adequately for congenital syphilis. And this creates a disproportionate outcome for this population. And this may be true for other populations you're serving as well. So really looking at who's affected and what the end outcomes are. All right, so with that, I am going to pass it off to Dr. Khan to really get into the difficult details. Get out your pens and notepads because there's a lot to listen to. Dr. Khan?
Thank you, Renee, for the introduction. Hi, everyone. My name is Dr. Khan, and I'm a clinical hospitalist and newer nursery attending. Thank you for joining us today. So let's get into the etiology and transmission when it comes to maternal syphilis and therefore congenital syphilis. The organism that causes syphilis is called Treponema pallidum, so T. pallidum. It falls under the species known as spirochete, and spirochetes are gram-negative bacteria. What's particular about these organisms, and this also ties into the name and the origin that derives of spirochete, which means coil or spiral, is that the organism itself appears like a spiral or coil and hair-like. And this makes them quite effective in penetrating mucous membranes and therefore disseminating early. They're highly invasive and they have the ability to enter the bloodstream, and that puts particularly our babies at risk because it leads to transplacental spread. So pregnant women can transmit syphilis to a child during any stage of syphilis and in any trimester of pregnancy. And Renee did mention this earlier, but the rate of maternal fetal transmission is highest in the setting of primary and secondary syphilis during pregnancy and decreases later with stages of maternal infection. The organism itself cannot be cultured in vitro, so the diagnosis requires a serological test, so a blood test. And the infection during pregnancy increases the risk of preterm birth and stillbirth if untreated. Next slide, please. We did touch on the epidemiology and current trends, but to emphasize the points that have been highlighted, the rates of congenital syphilis have increased by 81% nationally over the past 5 years, with approximately 3,941 cases of congenital syphilis in 2024. These risk factors overlap with migrant and seasonally agricultural worker communities. So therefore, these communities can be stratified into a higher risk. But if we're looking at maternal risk factors, we're looking at areas where the communities have high syphilis rates, multiple sexual partners, having a partner with multiple partners, or a history of incarceration, presence of other STIs, including HIV, recent immigration to the US, we mentioned incarceration, transactional sex, unstable housing, limited access to prenatal care, and other substance use disorders. I think it's important to also highlight that certain populations are higher at risk. And again, Renee touched on this as well, that particularly persons of color, so Hispanic and African American populations are at higher risk. And this is largely due to racial inequalities that have been longstanding in this area. And we can move on to the next slide. So you can separate the clinical manifestations in newborns based on early versus late. Early, the manifestations present at birth and within weeks, so 4 to 8 weeks after birth. And late goes after 2 years. So if we're looking at early clinical features, you have snuffles, which is copious nasal secretions, lymphadenopathy, mucocutaneous lesions, edema and rash, particularly its small dark red copper spots that is most identifiable on hands and feet, and can lead to systemic symptoms. So that can include pneumonia, meningitis, osteochondritis, so infection of the bone, periosteitis, and pseudoparalysis. And this is also related to the impact on bone. It can also cause hematological abnormalities. So that includes hemolytic anemia, as well as thrombocytopenia. And this can present as early as within the first few weeks of life. And we can go on to the next stage. The next slide, please. So late untreated infants, like I said, usually appear after 2 years of age. We're looking at more systemic involvement, particularly the central nervous system. That can lead to long-term impact that includes neurodevelopmental delays, as well as hearing loss, long-standing impact on bone, so they have particular clinical manifestations, which includes saber shins, which basically means anterior bowing of the shins, frontal bossing, so leads to a much larger prominent forehead, and Clutton joints, which are symmetric, painless swelling of the knees. It can also involve the teeth, which can include Hutchison teeth. These are peg-shaped, notched central incisors, as well as mulberry molars, which are deformed crowns which appear with multiple round enamel cusps. And this resembles the appearance of a mulberry, hence the name. Interstitial keratitis, which is related to affecting the vision, and a saddle nose deformity, as well as Raygade's, which is perioral fissures. And these manifestations can be treated, can be prevented by treatment and early recognition. You can move on to the next slide. So here we're looking at the main clinical manifestations in newborns that you can see. Going from right to left, we're looking at the desquamating and maculopapular skin lesions, which are punched out, pale blistered lesions mainly. In these photos, they're showing it on the ears and the nasal bridge, as well as desquamation of the feet and palms. The second photo looks at more late manifestation with hepatosplenomegaly and jaundice in an infant with congenital syphilis. You can also have rhinitis with mucopurulent nasal discharge, which is the third photo. And then the fourth is another late manifestation where you have X-ray of bone abnormalities. This is syphilitic metaphysitis in an infant with diminished density in the ends of the shaft and destruction at the proximal tibia. And we can move on to the next slide. So state prenatal syphilis testing. So the number of states that actually require testing in the first trimester are 43, the third trimester are 18, with 5 only if at increased risk, and 7 with 8 only at increased risk at delivery, and 7 states with no testing required at all. Next slide, please. So I think it's important to keep in mind that state prenatal requirements versus what should be the best practice related to your patient population and the risk. Ideally, what is recommended is 3-point surveillance, which includes at the first prenatal visit, in the third trimester, and at birth. And the testing should also include looking at, the relevant risk factors that can increase the risk of maternal syphilis and therefore congenital syphilis. It's also important to be aware of the treatment guidelines so that you are able to correctly identify and manage moms and their babies. Ask pregnant patients if and when they've had a syphilis test results in any treatment for both the patient and their partners, and ensure treatment completion based on the stage. And you want to make sure you're consulting your local health department. It's a notifiable disease. And then identifying the stages, the access to medication and partner services. Next slide, please. So screening and maternal evaluation. Pregnancy status should be determined for all women of reproductive age that are diagnosed with any stage of syphilis. And particularly women who experience stillbirth after 20 weeks of pregnancy should also be tested for syphilis, given the risk of syphilis being the cause behind stillbirth. The way that we diagnose syphilis is categorized into 2 different tiers, which is the non-treponemal and treponemal tests. And the non-treponemal tests are a screening measure, and therefore these tests can lead to a lot of false positives, which is why it is important to have a confirmatory treponemal test to follow. A non-treponema test includes VDRL, so Venereal Disease Research Lab, or a rapid plasma reagent. And how it works is it remains positive when exposed to reagent that is basically an antigen that is released after host cells rupture with exposure to Treponema pallidum, versus confirmatory treponemal tests, which are looking at the antibody testing, is looking for the actual bacteria itself. Next slide, please. So neonatal evaluation, the diagnostic approach looks at a couple of different categories. We're looking at moms, their actual serological tests, whether they've been treated, then assessing the infant themselves. So this then allows for stratification of risk. So the first thing you would do is looking at maternal history with confirming their serological testing, both treponemal and non-treponemal. Assessing the adequacy of maternal treatment. What I mean by this is the treatment itself had completed its course at least 30 days prior to delivery, and it was a correct regimen. Treatment for syphilis is benzathine penicillin, and it is the most effective and essentially the only treatment for syphilis itself. And this brings up a concern of potentially inaccess to treatment, as well as possible resistance when it comes to treatment, and when you are encountering families or moms that are allergic to penicillin. And in that case, you would think about doing penicillin desensitization. When it comes to informing infant evaluation, you would start off with identifying risk based on mom, followed by a physical exam to assess for signs of congenital syphilis. Getting a confirmatory test, if indicated, with a RPR VDRL, which should be consistent with mom's tests, and then comparing the titers. And that then allows you to be able to identify further diagnostic workup and management. Next slide, please. So guiding the diagnostic workup is based off the risk category, and we'll touch on this a little bit further. But essentially, the workup itself looks at the different systems that are involved when it comes to congenital syphilis. So CSF analysis, ECVC, long bone films. And then treatment pathway is then determined based off the risk category as well as the findings from your diagnostic workup. And this would essentially be a 10-day penicillin course that is IV versus a single dose of IM penicillin. Next slide, please. So this is an overview and a brief summary of the AAP Red Book's diagnostic approach to infants born to mothers with reactive treponemal tests. They've provided a conventional approach versus a reverse sequence screening approach. I've basically combined it to have an overview for the purpose of this presentation. If you go on the AAP website, you can actually find a diagnostic algorithm which can help you in stratifying risk for infants that are born to moms with syphilis. So again, first and foremost, confirming maternal syphilis status, which would be with our testing as well as the treatment and whether it was adequate. Evaluating the infant themselves by looking at the physical exam findings and confirming with a infant treponemal test. Then comparing the titers to be able to assess the likelihood of infection, which then allows us to assess and assign the risk category and follow with evaluation and treatment. Next slide, please. So the first category that we're going to talk about is proven highly probable congenital syphilis. What this includes is findings of an abnormal physical exam, which is consistent with congenital syphilis, or serum qualitative non-treponemal serological titer that is 4 times higher 4 times higher than mom's titer, or a positive result of dark field test or PCR assay of lesions of bodily fluids. If your infant meets this category, the recommended evaluation would then be going forward with a CSF analysis with a lumbar puncture, which would include a CSF VDRL, a cell count and protein, a CBC, and a differential, and a platelet count, and other tests as clinically indicated, which would include an X-ray of the long bones, a chest X-ray, neuroimaging, your transaminases, and an opto examination. Treatment includes aqueous crystalline penicillin G, which is 50,000 units per kilogram IV Q12 hourly for anyone that is 1 week or younger, and then Q8 hourly for infants that are over 1 week of age. And the duration for this treatment course should be 10 days. Or we can look at, a penicillin dose with an IM single daily dose for 10 days if the option for IV is not available. Next slide, please. The next category is possible congenital syphilis. So this is where the examination of the infant is normal, and a serum quantitative non-troponemal serological titer is either equal to or less than that of 4 times of mom's titer. And one of the following: either mom was not treated, was inadequately treated, or having no documentation of treatment. She was treated with a regimen other than what was recommended, or she received the recommended treatment under 4 weeks prior to delivery. The recommended evaluation is continue to do a workup and follow the workup to see if there is any further signs of developing congenital syphilis. Next slide. Treatment in this case, if workup is positive and we're meeting criteria, would be again a penicillin G, the same dose IV Q12 hourly for 1 week or younger, then Q8 hourly over 1 week of age for a duration of 10 days. And then other options can be the IM daily dose for 10 days or a single dose recommended by some expert, but only if all components of your evaluation are normal and you have clear follow-up delineated. Next slide, please. Less likely congenital syphilis is the third category. So this is where the examination again is normal. A serum quantitative non-troponemal serological titer is equal to or less than 4 times of mom's, and both mom was treated during pregnancy. The treatment was deemed appropriate for the infection stage, and it was initiated at least 30 days prior to delivery. And mom has no evidence of reinfection or relapse. So what I mean by that is that the titers of mom is not rising compared to the baseline. So it should still remain at least 4 times or below the previous titer that was attained by mom at the time of infection. Infants whose mom's non-troponemal titers decreased at least 4 times after appropriate therapy for early syphilis or remain stable to low titer can be followed every 2 to 3 months without treatment until your non-troponemal test becomes non-reactive. And here, the single daily dose of penicillin G IM is warranted. Next slide, please. The fourth category and final category is unlikely congenital syphilis. This is where the infant's examination is normal. The RPR-VDRL is equal to or less than 4 times mom's titer, and both mom's treatment was adequate before pregnancy, and there's no evidence of infection. So the titer has remained low and stable before and during pregnancy and at delivery. The evaluation here is not recommended. And as far as treatment, a single dose can be considered, but if follow-up is uncertain, I think it would be warranted, but it's not recommended. Next slide, please. So we did touch on follow-up, but it's important to understand that we would want to ensure at least every 2 to 3 months having a appointment scheduled with the mom and baby to ensure that we are not missing development of congenital syphilis. The titer is expected to decrease by 3 months and turn non-reactive by 6 months. A persistent titer, however, at 6 to 12 months may require further evaluation with a lumbar puncture versus considering retreatment. At this point in time, we should think about involving infectious disease for recommendations. If you're seronegative at birth but at risk, it is important to check another serological test at the 3-month mark to rule out incubating congenital syphilis. If workup was done and that included a lumbar puncture and initially the CSF returned abnormal, you don't need to repeat a lumbar puncture unless you're seeing a rise in titers at the 6 to 12-month mark. It's important to connect with your local health department and involve your disease interventional specialist, which can help in managing your cases. Next slide, please. So looking at prevention strategies, universal maternal screening, as I had mentioned, it is recommended to have a 3-point screening system, and that would include the first prenatal visit, third trimester, and at delivery. And although this isn't something that is state mandated, if you are in a region which has higher risk communities and you're caring for them, then it's recommended to follow this 3-point strategy in screening. It's also important to manage and treat immediately, so providing penicillin G and ensure completion of treatment prior to delivery for our moms. Prevention is key when it comes to treatment for partners and involvement of support of your disease interventional specialists. And here, this is trying to reduce the risk of re-exposure after treating moms. It's also important to strengthen early and consistent prenatal care access. So here we are looking at establishing better access to care for especially at-risk communities, as well as providing care that is non-judgmental and open-ended to allow for at-risk communities to feel comfortable in being able to access care and provide their background when it comes to the risk for syphilis. It's also important to repeat titers during pregnancy to confirm response, as I mentioned, and address health-related needs. So this is where we're looking at social determinants of health, as well as other factors that can influence the risk of syphilis. And that includes housing, substance use, incarceration, and limited care access. As providers, I think it's important to have structures in place within the system to allow for better recognition as well as management for our patients, which includes the electronic health system prompts, where it correctly identifies at-risk individuals and allows us to be able to correctly follow them and promptly to then rapidly provide treatment and access to treatment, as well as report to public health. Next slide, please. And these were the references that we used in the making of the presentation. Thank you all for listening, and I think we're open to questions and comments.
Yeah, thank you so much, Dr. Khan. Thank you to Renee. We really appreciate your time. I'm going to stop recording and